Welcome to our first breakout session on innovation and clinical care. I want to thank everybody for joining us today. I also want to send a big thank you to the sponsors of this conference. It wouldn't be possible without them, so thank you very much. A couple of reminders before we get started with today's session. Please use the chat or the Q&A section to ask questions of our speakers anytime during the session. I'll be monitoring those along with Chris, and we'll also have some time for Q&A at the conclusion of each presentation. So the goal of this session today is to explore really how care coordination is enhanced through utilization of health information exchange. And we are pleased to have Dr. Russell Leftwich with InterSystems and Dennis Sulcer, CEO at Youth Dynamics in Billings, as our speakers today. So before we find out how utilizing an HIE will positively impact patient care, it is my pleasure to introduce your speakers. Our first speaker today is Dennis Solcer. He is, as I said, the CEO at Youth Dynamics in Billings and brings an extensive background in education, business, and healthcare. Prior to his experience at Youth Dynamics, Dennis served as the CEO and the president at St. Vincent Healthcare Foundation, administrator at the Children's Clinic, and in the Billings School District as a high school principal. He has a passion for teaching, learning, and leading children as well as people. He believes education is the key to a successful and healthy life. As CEO, Dennis leads our organization and is passionate about helping families find care they need to succeed. The people of Youth Dynamics are driven by supporting the children and their mental health needs. Dennis is a native Montanan. He grew up with parents who were both educators and always valued learning and growing, which naturally rubbed off on him. Dennis says growing up, he wanted to be a teacher his entire life, and he continues to teach as CEO of Youth Dynamics. Dennis states that leadership is about teaching and influencing others. Just like my mother and father, I want to impact people. So without further ado, I would like to present to you Dennis Sulcer. Thanks for being with us, Dennis.
Thank you, Kurt. I hope that everyone can hear me, and I appreciate the introduction. It has something to do with my first slide, and just tell you a little bit about myself and the reason why I'm engaged today. More than anything else, I think I was a late entry the last couple of weeks, taking the place of another presenter, but I have had experience with data-driven decision-making over my career, both in education and healthcare. And I'd like to share with you why, essentially, Youth Dynamics, a children's mental health agency, is joining Health Information Exchange in Montana, Big Sky Care Connect. So I'm gonna try to share my screen, and hopefully it will come across to all of you in a big way here shortly. Oh gosh darn it. I don't know if that's coming across or not. Can you see that?
Corey here can't see that on the screen, so make sure, yeah, you launch it and then share that screen particularly.
Let's see, I'll give this another try here. Apologize for the delay. the screen I want to share just isn't coming up. So,
Oh, there we go.
are we
Oh,
good
it is
now?
sharing the entire PowerPoint background, but yeah, if that we can still see the slides in there.
As long as you can see it. I apologize for the delay. As I was introduced by Kurt, he mentioned that I had been in education for several years, and part of my background tells you a little bit why we've chosen to move in the direction of our health information exchange. As an educator, I truly believed in data-driven decision-making and interventions. And I did my research in a doctoral program in data-driven instruction and how to base your instruction on data-driven decisions, and studying results and how children were performing based on instructional strategies that would inform your instruction. And I truly believe in that, and it's where I'm coming from as an educator, and it's transferred into my second life as a healthcare professional. So I truly believe, and I'm trying to culturize our particular organization, that we learn from the analysis of information. And we do have on in the audience one of my colleagues, Maddie Zwiffelhofer, and Maddie is really part of our decision-making team. She runs our information that we use in our electronic medical record, and I really appreciate the information that we get from her daily. And then as a clinic administrator for 7 years in a pediatric clinic, and I'm going to give a shout out to the Children's Clinic of Billings. That's where I worked for 7 years, and we did a lot of transitioning to data-driven decision-making. One, implementing an electronic medical record for the first time ever, joined with Denver Children's Hospital as an Epic provider, and Epic really made a difference for us. And lo and behold, I think one of the aha moments for our providers in the children's clinic was that when you could click that Care Everywhere button and get information about your patient that didn't exist within our record. And it was just awesome to have that capacity. And I actually had a conversation just the last couple of weeks with the current clinic administrator at the children's clinic, and they are certainly making a consideration for joining Big Sky Care Connect, and I hope they do, because we share some of the same patients. And then as a hospital care site development director at St. Vincent Healthcare, I was deeply involved in PEDS project that we were part of at the hospital. And as a development director, we did a lot of fundraising for pediatrics, and that was one of our primary goals annually, is to support funding to pediatrics. And one of the things that we know all too well is that even here at Youth Dynamics, we have children that frequent the pediatrics program at St. Vincent Healthcare, and having that connection. And I don't know for certain if St. Vincent Healthcare has made that full connection and commitment to Big Sky Care Connect as of yet, but it certainly is a connector for us in serving children. And then finally, my time here at Youth Dynamics has been for the last couple years, and as a children's mental health agency, we see the benefits each and every day of being connected to health information across the state of Montana. And I'll tell you just a little bit about ourselves. Hoping I can get to the next slide. Is that coming up?
Yep, serving Montana.
Yes, serving Montana since 1981. So we've been in existence for 40 years. And if you take a look at the map, all those dots are places that we have either group homes and or community offices. So we have an extensive network across the state, and the kids we serve can come from anywhere in Montana. And our mission is that Youth Dynamics provides family-focused behavioral health treatment founded on the principles of an actively caring and trauma-sensitive culture in which people can realize their full potential. And we believe that being a trauma-informed agency, the access to information about what has happened in the lives of our children, whether it's their healthcare interventions or other interventions in behavioral health scenarios, is really important for us to help understand their trauma and the things that they have come to us with. The reality is, in our business as a behavioral and mental health care provider, not many of the children come with a predisposition with mental health issues. Most often those mental health concerns are caused from a trauma, and knowing that background of the child is really important for us in order to serve them better. The next slide is a little bit about our core values, and almost every one of our core values points towards us being a data-driven decision-making team, and also having information and full disclosure of what's happening with children is most important for us. And you can see the second, or even the first one, empowerment and partnerships and collaboration. We see the health information exchange as that in Montana. We also believe in open and respectful communication, and communication is what this health information exchange is all about. We truly believe that that's important. When we make team decisions, we consider the entire individual in making those decisions about treatment plans and what have you. So our core values truly address us being part of a health information exchange. The value of the health information exchange is only more powerful when you have lots of people join up. And we're happy to be part of kind of the ground floor of participation. Also, you can see one of our core values is in trauma-sensitive culture, and working a trauma-sensitive agency. Understanding the background of children is ultimately very important for us. The next slide just shows the number of locations. This is, again, is the number of locations that we're serving children. We may not have offices in every one of those locations, but we truly are serving kids across the state of Montana. And every one of those little orange dots is where one of our children is located. So on an average basis, annually, we're serving upwards of 2,700 kids across the state of Montana in their mental health care needs. These are the things that we provide. I'll start up at the top. We have therapeutic youth group homes, or therapeutic group homes for children. Actually, we have 10 across the state of Montana, and we have a capacity of 80 beds in those group homes. Each of them house 8 children and a core of workers on a daily basis. Service and care coordination and support, that's truly our case management piece of our business. And it's really those two pieces of our services are really important to have a participation in the health information exchange. We have youth mentors. They're basically our family support assistants that go out and help kids in mentoring and also connecting with their families. Individual and family therapy. We have a group of therapists that really cover the entire state. If they're not doing it face-to-face, they do it through telehealth. And we really have experienced this last year anyway, telehealth growth, given the COVID situation. Parent education and support, we provide that. We also do substance use education. It's on an outpatient basis, but a lot of our kids in the group homes have co-occurring disorders, mental health, and substance use issues. So that's an important part of our delivery service as well. And then we have foster care, and our foster care is therapeutic foster care. Therapy isn't delivered in the homes, but the families are trained in understanding what therapy does for a child and the therapeutic component of housing a child. These are how our services are provided across the state. This big slice here shows that we have 2,200 kids or more receiving case management, which means almost every one of the children that we provide services for have case management. And of course, those of you that understand case management and the value of case management, you know how important health information exchanges is for those kids and their families. Another piece that I just wanted to point towards is our therapeutic group home. We actually serve about 200 kids annually in our group homes. And one of the pieces about group home is that every one of our children must have a well child check within 30 days of entry into a group home. So there again, the health information exchange is an important piece of what providing us information about those kids. The next slide is just a little bit about our gender distribution and the kids we do serve. We serve approximately 3,200 male services. That means not 3,200 individual males, but delivering services to males, 3,200 different services. And then our female population is a little smaller, and you can see how that distribution is provided there. That's just a little bit of our demographic. The next slide shows our distribution according to race. And one of the things, obviously, we serve a large Native American population. I think the Native population in Montana represents 6 to 7%, if I'm not mistaken. We served in 2018-19 about 30% Native Americans of our entire population. And this last year, 2019-20, which we haven't updated this yet, we served 37% of the kids that we serve are Native American. So, you know, that's a big population, and we feel like it's a really important population. And on top of all of that, 90% of our children served are Medicaid eligible. So given that the Medicaid eligible and Medicaid patients in Montana are all going to be participating in this exchange, that's a big part of our population. We have some information through Medicaid then on about 90% of the children that we serve. So it's really important for us as we serve the poor and vulnerable children across the state to dial into that and have information about them beyond what we know as a behavioral health agency. The next slide just shows diagnosis distribution by services in the year 2018-19. Our 2020 year just finished, and we haven't updated that slide yet, but you can see some of the diagnoses that we are serving children. And I think this just gives you the audience a good background about who we are serving and why we would want to be part of this exchange. And you can see the largest number, trauma and stress or related disorders, 2,600 children annually. Almost every one of our children we serve has trauma in their background, and understanding and sharing that information, not only with our providers within Youth Dynamics, it's really important for the pediatric providers across the state to have the information that we can share about our children, especially when they have a medical health need. And that background information is really important for pediatric providers. I know that's one of the conversations that I had consistently each and every day with the providers at the Children's Clinic is, you know, we know a lot about their health background, but it's difficult for us to determine what's happening with them in their real life background. And oftentimes that mental health and behavioral health connection is important for them. So we're glad that we're going to be able to provide that for providers across the state as we join the Health Information Exchange. Again, I just want to go back to what we do in our therapeutic group homes and how we provide services for kids. We have therapeutic group homes in Billings, Boulder, Great Falls, and Helena, and there's 10 of them all together. We provide for youth between ages 8 and 18. We don't have very many children under the age of 10, but that's our demographic. And we provide 24-hour supervision and treatment advocacy and therapy within each of those settings. So we are providing therapy weekly to the kids that are part of that group home setting. And again, it's a small population of Montana kids, but at the same time, probably some of the most vulnerable kids in the state. And it's really important, especially as a caregiver, to understand that background. Our expectation is that most of these youth will eventually be able to return to some kind of family setting. And oftentimes we'd like that to be the original biological family setting. And there are transitions that take place within that. And one of our goals as an agency is to improve our transitions of care and transitions into adulthood. And truly, I think providing information in a health information exchange is part of helping those transitions along, especially when we can pass information seamlessly along to providers, regardless of the continuum of care that those providers are on. Having that information, making good decisions about care and interventions with the children that we're serving is just really a critical component to healthy outcomes and better outcomes for kids. So we're just all in. I think you can get it from what I'm trying to present, is that we really truly believe in sharing this information, because we all can be better providers in doing so. I just want to talk a little bit about youth case management. And for those of you that understand it, pardon me for kind of going down into the basics, but oftentimes parents and families feel stigmatized and have trouble gaining access, especially for mental health care benefits. And truly our case managers help them navigate that. Our case managers are advocates for community services, and it doesn't matter what kind of community services that is, whether it's health, vision, dental, etc. Just making connections to the community for those kids that need it. That's a primary focus of our case management. And our case managers really, truly know inside and out what that family dynamic is all about. And they're doing a great job with the kids and helping them access services. And this health information exchange will help us do that, and will also help healthcare providers know more about the children that they're serving, especially as they come from their case management pieces in as we serve them in youth dynamics. It also helps the youth case manager help guide parents and guardians in maneuvering the system, if you will. While I was at the Children's Clinic, we implemented a parent helping parent kind of program in sort of a case management model. It is difficult to maneuver through healthcare, especially in a family that isn't familiar with it, and not only healthcare, but mental health care and services that kids do truly need. We see case management as really a strong component for that. We have approximately 50 case managers across the state of Montana, and truly, like I said earlier, almost 2,200, 2,300 kids that we're serving annually are receiving case management services. And we serve some kids that don't get services at Youth Dynamics. We're serving kids outside of our agency and their case management needs. So that's really a critical component to what we're doing across the state. And sharing this information is key in effective case management. again, like I said, the health information exchange is a tool, and a tool that we see as advantageous in better serving our kids. And it's a point of reference for our youth case managers and the child. So we're excited about getting this started and actually actively participating. And quite honestly, I'm advocating that every children's mental health agency across the state joins up along with us. But not only that, you know, healthcare providers, wherever they might be serving pediatric patients, participate. It'll help us all do a better job, and I know that our outcomes will improve because of it. One of the last slides I just wanted to mention is that wellness matters, and wellness matters to us as an agency. And as you can see, it says our goal is to help all of our families find the highest quality medical care, and oftentimes we are in the middle of that in serving mental health care needs, not only serving them with services that address their mental health needs, but it's everything that surrounds that. We look at the whole person in their healing, and oftentimes kids have difficulty with just dental needs and taking care of their teeth, and you know, maybe they haven't had an eye exam for, you know, quite some time, and that vision is an issue, and them performing as a human. And we truly want to try to address those needs. Our primary goal for all of the kids that we serve that each and every one of them have a primary care physician. That's ultimately important for us. And we see the health information exchange helping us and helping us guide that connection to a primary care physician, whether they already have established it or we can help them establish a primary care physician if they haven't already. That's a primary focus for us in how we address children and their needs, mental health care needs. So I just want all of you to know the piece that we're playing, and I wouldn't say that we're alone in that, in addressing mental health care and behavioral health care needs of children across the state. Our fellow providers are really integral in delivering those services, and their goals are the same for kids, and they know how not only are their mental health care needs needing to be met, but their physical health as well, and it goes hand in hand. So we're pretty proud of what we're trying to do and making those partnerships and collaborations. So the last slide I have really addresses the health information exchange and Big Sky Care Connect. You know, when I heard that this was happening, and I learned it through the Behavioral Health Alliance of Montana, I want to thank Mary Windecker for bringing this to all of us who are members of BAM. But these are good reasons for us to connect. We want to help provide other providers data about the kids we serve. You know, that's really important. I see that as a real value of Big Sky Care Connect. It helps us make data-driven decisions for individual treatment plans. Each and every one of the children that we serve has an ITP, and making the decisions about that individual treatment plan involves a lot of communication, and not just what the information that we have as an agency. It's really important that we examine the entire child in making those decisions. And the third point I make is we are a trauma-informed agency and a culture. We want to know what has happened in that child's life that presents here in our agency. What's behind all of the behaviors? What's behind the mental health issues? What's going on, and what trauma has occurred? When I began this venture as a mental health care provider and leading this organization, I listened to Jim Fitzgerald out of Intermountain early on in my start here, and he just said, ultimately, kids experience trauma, and that's 90% or then some in relation to their mental health needs, and what is that trauma that they've experienced. So that drives who we are here at this agency. And I dare say it drives most agencies across the state that are dealing with children. We want to drive best practices and trauma-informed care. So, this helps us to be a best practice agency. And this ultimately results in better outcomes and better chances for kids. So that's my presentation. That's my 2 cents worth in kind of this, my novel perspective on a health information exchange. And I want to thank Big Sky Care Connect for asking us to be participants. I know you got a heck of a lot about youth dynamics today, but that's who we are, and that's how we fit into this equation. And I truly believe from my past experiences, whether they're as an educator, as a medical health professional, or an administrator, even at the hospital level, that we truly believe in data-driven decision-making and doing what's best for kids. And more information is better than less in making those decisions and driving outcomes. So that's our perspective, and that's how we operate as an agency. Thanks again for asking us to be part of this.
Dennis, thank you so much for your presentation, for sharing about youth dynamics. I think it really highlights the importance of care coordination in a state that's as large and at times rural as ours is. Pretty clear that you have not only patients across the state, but some of those obviously, as they're moving in and out of care, are very mobile. And the critical nature of having access to records relatively quickly must be not only very important to you as you treat children, but also for those providers that may be treating those kids back home, which may not be in one of your youth homes or other facilities. Could you talk a little bit about what information or data that you think youth dynamics will be contributing to the HIE that's really going to be helpful for those pediatricians or other physicians and providers when these kids go back to their families or go back to their original locations?
Yeah, I think diagnosis that may not appear in their health record, their mental health diagnosis is one. That tells a lot about the story, particularly to pediatricians that may not have that access to that information in a first encounter, for example, and especially if a child is maybe mobile, as you suggested, Kurt. That in and of itself is an important piece of information that we can provide. The other thing is, I truly believe too that those kids, and we are really serving the poor and vulnerable in our agency. 90% are Medicaid eligible and receive Medicaid support. Oftentimes that child is not the one that gets, it has the great fortune of wonderful family life and support, and having that information available to whatever provider that they connect with is so important. I can't emphasize enough that the services, and even the services that we provide, whether it's family support or case management or direct therapy, that being noted in that record is important for the care provider to see firsthand what has been done in the past. And I have had lots of conversations with pediatricians and teachers, for that matter, about what's going on with this child. Why, they don't know the story behind them. And if we can contribute to that as a mental health agency, that story behind the child, that is so valuable. And those data points will be there. One piece of information that I'm pretty certain will be shared is what we're endeavoring in at the state level. We're administering the CASI assessment. All of our kids that have case management will be taking a CASI assessment. And we'll do that every 90 days. This is an initiative of the state. So all of our kids will have that CASI assessment on a every 90-day basis. And that tells a little story about how the child is improving in their mental health care needs. So their scale, as they as they go up the scale, we can see progress or not. And that's one measure that might be important for a pediatrician to see.
Excellent. Thanks, Dennis. We do have some questions from the participants today. So thanks for your questions. And please, if you have any other questions for Dennis, feel free to type them in the chat and we'll get them to him. The first question, Dennis, is the participant wants to say thank you and was wondering what electronic health record you use. They're also curious if you're able to collect and utilize some of the social determinants of health data for either the child or the family.
Those are great questions, and I'm glad you asked because I think I know the answers. First of all, we use Sigmund Aura, and it's kind of a professional electronic health record that is primarily for mental and behavioral health. We've worked with our provider, Sigmund Aura, to make the transition and the conversion and connection to Big Sky Care Connect. So we're working down that path, and we've made an agreement with them to get that done. The second question in regard to the social determinants of health, we just went through our CARF accreditation, and that was one of the pieces that we brought forward. One, we are joining the Health Information Exchange, but we're also going to begin collecting data and data points on those social determinants of health care. And we are really, truly going to make an emphasis in populating that within our electronic health record. So that's a good question, and we're glad we're moving in that direction. I think it's important for all of us to help determine that and where that child is and what things in their social background are driving where they're at in their healthcare needs. So appreciate that question, and it is top of mind for us as well.
Excellent. Thanks, Dennis. I'm not seeing any other questions from our participants. I do have one other follow-up question from your presentation, which was fantastic and raised a lot of curiosities for me. And as you know, Dennis, my partner Wendy, and I with FutureSync, we travel around the state and we interact with lots of different healthcare professionals. And obviously, behavioral health is at the top of mind, and how to manage that from a physician perspective. And we also hear from different hospitals that do share information with similar or the same EMR providers. And you mentioned a little bit about a specific EMR when you were a hospital administrator, and I'm curious about this. You may not share that EMR now, and we talk about care coordination. Can you talk briefly maybe about why would it be important for, let's say, a hospital with a large EMR that can share data with other hospitals using the same EMR to join the HIE? Why is that important to you?
Well, it was real exciting for me to be part of the Children's Clinic and St. Vincent Healthcare, who were on the same platform, Epic. And there was great information that got exchanged. And I know the pediatricians that I worked with truly valued that opportunity to have that quick information exchange, even though they weren't on the same platform. The Children's Clinic was connected to Denver Children's, but it was Epic and Care Everywhere that made that connection for them. So I see the same concept with the Health Information Exchange, only it being larger and encompassing everyone. And I truly, as a mental health care provider in the state, I want information from Beneficiary, I want information from Billings Clinic, I want information from St. Pat's, I want information from St. Vincent, because that helps us provide better care for all of our kids, not just the ones that are connected to one hospital. So my perspective is the Health Information Exchange in Montana will be so powerful in sharing information and kind of on demand. We have to wait for records often here, and waiting that downtime might mean the difference in doing the right intervention at the right time for a kid. And having instant access makes us better at what we do.
Excellent. Thanks, Dennis. One other question popped up, and it's just wondering if you would be willing to share your contact information for participants to reach out. So if you're willing to do that, Dennis, maybe we could get you to type your contact information in the chat area so people would have that. That'd be great.
I'll do that. Thanks a lot. Thanks a lot.
Excellent. And thank you. Thank you for your presentation. Well, next up, folks, we have Dr. Russell Leftwich, and Dr. Leftwich joins us today from InterSystems. He is the Senior Clinical Advisor for Interoperability with InterSystems Corporation, who is a vendor for electronic data technology in healthcare and other industries. His responsibilities at InterSystems include supporting healthcare data standards compliance in the US and internationally. And prior to his current position, he served as the CMIO for the state of Tennessee Office of eHealth, supporting health information exchange in Tennessee. In this position, he chaired the clinical work group and medication history projects for the state's HIE efforts. And he also acted as a liaison with several efforts in Tennessee communities to leverage health information exchange for community care coordination. He currently leads efforts in standards development organizations to develop electronic data standards to support care planning and electronic communications across patient-centered care teams. His background also includes 2 decades in internal medicine practice as clinical assistant professor at Vanderbilt University. And he is currently an adjunct assistant professor of biomedical information at Vanderbilt. So we are very lucky to have Dr. Leftwich's expertise today, and it's my pleasure to introduce him to the panelists. Thank you, Dr. Leftwich.
Thanks, Kurt, and thank you, Dennis, for your presentation. It was a great setup for me to talk about care coordination, and I think great inspiration. So let me see if I can successfully share my screen here. All right, I believe you should be seeing my PowerPoint now.
Looks
Yep,
great.
we're seeing it great.
So I want to talk today about care coordination at a higher level than Dennis has talked about. But as I say, I think his was a great setup. My references are largely at the other end of the age spectrum. However, I think the workflows of care coordination are the same regardless. And the issues around sharing data, securely accessing data about individuals to support care coordination by the team that takes care of each individual is very much the same at different ends of the age spectrum. So I have an analogy that I like to use, that care coordination should work like the NFL on Sunday, and should be aware of what makes NFL teams competitive on Sunday. But
believe it or not, even to this day, there's patients who they show up at their doctor's office and they say, I was in the hospital for a month. And the doctor didn't know that they were in the hospital.
So that little video clip may seem extreme, but it happens. And it seems in those cases like it's not an NFL game on Sunday, it's a pickup game on Saturday. And the players don't really know each other, how to get in in touch with each other, what the other players' skills are, and so forth. And I'm afraid that's more like we're often doing care coordination today than the game on Sunday. As our population ages, the portion with multiple chronic problems is steadily increasing and will continue to do so. And that's an important factor in the need to improve care coordination in order to improve outcomes. And I think from the perspective of the individual as a patient, each one of us, and we're all patients at some point, each one of us has the idea of a virtual team of caregivers and providers who provide our care. We refer to my doctor, my nurse, my therapist, my medical equipment supplier, as if they're a team. But those individuals, they don't really think of themselves as our team. They may well know each other, but they're not really aware that they're collectively taking care of us as an individual. And that lack of awareness makes care coordination difficult and unlikely. So one of the dramatic statistics that you may have seen is that the average Medicare beneficiary in the US sees 7 providers in 4 different organizations in a year. That's the average Medicare beneficiary. How many of those providers know who the other 6 are? Probably not very many. But if we move to more complex patients with more complex conditions, then there are obviously a lot more than 7 providers and often more than 4 organizations forming this virtual care team, unaware that they're caring for the same individual. And part of the lack of coordination also comes from not having the right information at the right time in the right place. There's another statistic that I think is fairly telling, that when a patient in the US first sees their primary care provider after a stay in the hospital, 75% of the time, that primary care provider does not yet have the discharge summary from that hospitalization. And that's certainly the opposite of care coordination, if you will. And it is a cause of many patient safety issues and missteps in the course of patients after they leave the hospital, and indeed the reason for many hospital readmissions is this failure of transfer of essential information when patients do leave the hospital. So how do we get the information we need and don't have when we see those patients who've been discharged from the hospital, or the patients who are back to see us for follow-up or because they have a new problem? Well, do you remember this game from when we were children? The game of telephone, where one individual has a message written on a piece of paper and they read it and then they whisper it to the next person and so on down the line. And you remember that the message is always completely upside down and distorted, and everybody laughs because at the end of the line, it's not what the message was at all. But that's the way we exchange information, caring for patients every day. We use workarounds. We ask the patient who just left the hospital, what medications did they discharge you from the hospital on, as if they could tell us the names of 8 medications and the doses. We asked the patient, what did the specialist I sent you to see last week tell you? What did they find on your MRI exam? As if we could get an accurate representation of that information from the patient. But this is the information we use to care for patients. Or we yell down the hall to somebody on our staff to call the emergency department and find out what the laboratory showed last night when this patient was in the ED, or call the pharmacy and find out what the new prescription they filled was. This is how we exchange information too often today. And I think in practice, this was an everyday occurrence and continues to be. But to have care coordination to improve the care we deliver, we need real information that is accurate and usable. And that's what health information exchange, that's what Big Sky Care Connect is all about. So I'm not going to suggest that anybody has time in the day to create a care team representation for every patient they see. But I think it is essential that we do that for some of the more complex patients that we see, where care coordination is just beyond doing effectively if we don't have a knowledge of who the team is that cares for that individual and where they may have information. And so I would suggest that the patients that we start with, that we focus on with this idea of defining their care team, is that portion of patients that are sometimes referred to as high needs patients. And you may be familiar with this statistic that still is hard for me to wrap my head around, even though I've seen it now for some time. But in the US, the 5% of individuals with the most complex health problems utilize 50% of our healthcare resources. That's astonishing. Those are the people who I would say suffer from lack of care coordination. Their outcomes are profoundly affected. They have more patient safety issues, medical errors than the average patient. And those are the individuals that I think we should start our focus on to develop this workflow that we call care coordination and be able to improve the outcome of those individuals and eventually carry it to a less complex care. So my analogy about the NFL and care coordination, well, what does it take to make NFL teams competitive on Sunday? Well, first they have a team roster. They know who's on the team. They know how to contact those people on the team because they've got to set up practice and travel and so forth. And very importantly, on an NFL team, everyone knows what role they're playing. They're responsible for playing their position. they accept that responsibility because it's essential to the team's success. There's a game plan. There's always a game plan. And everyone knows the game plan and tries to follow it. But if something happens that's not part of the game plan, then there's a signal from the sideline, an alert that something unexpected has been seen, and the players on the team need to know it. And lastly, the coach shares the scouting report on the opposition, what to expect and what is the best way to deal with this opponent. Those are the things that I think have analogies in care coordination and taking better care of the patients that we see. And those are things that the HIE, like Big Sky Care Connect, can help us to do and execute. First is that team roster and that contact information. Well, I would like to tell you it's easy and it's going to be there when you log on to the HIE, but that's not true. I do have a vision that there will be a day when the care team for this individual patient will be right there on their summary page, along with their medication list and their problem list and their allergies. It will say care team, and it will list who cares for that individual, because I think that should be the objective of improving care coordination and making it really work the way we want it to. But certainly, even without that, knowing who else is on the team for a patient that we're caring for or managing their care is really essential. Seeing the longitudinal care of the patient is the first step in understanding this. And in InterSystems technology that will be the basis of the Big Sky Care Connect, we call the longitudinal representation of an individual's care the unified care record, something that you see when you log on to the HIE. You can see and identify other providers and facilities where the patient receives care. And you can know who you need to communicate your plan to on that care team. And that's all functionality that is part of the HIE that will be a Big Sky Care Connect. I'm not going to get into a lot of the details of our technology or our HIE app, if you will, but I will show you a couple of screenshots. This is not a live demo. These are just pictures of a summary page for a fictitious patient named Raymond Chan. You see that his diagnoses are visible, going back to the recent past, and you can see more by clicking on next if there are more diagnoses. You see the allergies that an individual has, and you see their list of medications, and where that and a list of documents. And I will explain to you that this unified care record that you can see for a patient is not something that's stored. It's actually created in real time from the data sources that exist for that individual, and it's shown to you on a browser, so you can look at the details for that individual patient. And if we clicked on this screen on the tab there that says encounters, you would then see this screen that is a list of all the encounters that this individual has had, the provider who was the responsible provider for that encounter, the facility where that encounter took place, and this is both hospital visits, including emergency department visits and outpatient visits. And then you can see more details by clicking on those individual encounters. But my point is that you can see who the care team for this individual is by the providers that the individual has had contact with, has seen for an encounter. And Dennis mentioned earlier that first visit with a patient. Well, imagine how much more informative this information is looking in the HIE at this list of encounters versus asking the patient, well, what providers have you seen the past year or two? Naturally, this is far more informative and far more useful for care coordination. And it actually gives you access to additional information about each of those encounters. You've seen the summary page that already shows you the patient's current problems and medications, but depending on your reason for seeing the patient today, or perhaps you're not seeing the patient, perhaps you're a case manager, a care manager who's planning for this patient's future care, you need to know perhaps more details of these encounters that a patient has had, and it's available through the HIE to view and see in real time in a useful way. The other important thing that I will mention about this HIE technology is that it's a browser-based viewer. And that actually means that you can view this longitudinal record and the details of it on mobile devices. This is a screenshot of an iPhone for a different patient, but looking at some detail in their unified care record in an HIE, and showing you actually a graphic representation of some data about this patient. We certainly recognize that in this population of the most complex patients that arguably need care coordination the most, that they are not in the clinic, not in the hospital most of the time. They're at home, receiving home care. They're in an extended care facility or in some other situation receiving care, which might include social care, behavioral health care. This ability to view their unified care record on a mobile device greatly facilitates the care coordination of those individuals in the environments where they really spend most of the time, which is not, as I said, the hospital or the clinic. So to get back to my NFL analogy and the idea that everyone on the team has a role to play, and taking responsibility for your role as a member of a care team, I think is extremely important because a lot of gaps in care, a lot of medical outcomes that aren't good, aren't even reasonable, happen because there was a failure to take responsibility for some aspect of an individual's care. Dennis mentioned social determinants of health. We are coming to realize, or at least we're starting to verbalize the fact that these social determinants of health are critical factors in the care of many individuals, particularly individuals who are in those high-risk, complex needs populations. And I think one of the responsibilities that we all have as care team members is identifying the barriers that those social determinants present to an individual's health. And certainly HIE helps us in identifying those social determinants. Reconciling medications when it's an appropriate part of your role as a provider is another often missed responsibility because medication errors continue to be the #1 patient safety event in our healthcare system. And I'm not really talking about medication errors in a hospital, but those happen too, and they're important. But I'm talking about medication errors that are a result of failure to reconcile medications when patients go through transitions of care, discharged from the hospital, discharged from some other facility, or follow up after they've seen a specialist, and they wind up taking duplicates of the same medication by different names, or they wind up inadvertently stopping a medication that they should not have stopped. So reconciling medications is one very important part of care coordination that is very much facilitated by health information exchange and by access to a patient's unified record, longitudinal care record, and seeing medications that they have been on and medication changes that have been made. Identifying gaps in care visible in the HIE. As obvious as a patient was in the hospital, but that was 6 months ago, and they have no outpatient encounters, no clinic visits since then. That is likely not the intended care that they were to receive after that hospitalization. And you can see it in that unified care record. Following up on tests and treatment that you ordered or prescribed is extremely important in care coordination, or identifying that there is a lack of follow-up of some change in the patient's therapy or some test that is in the HIE but has not been, has obviously not been acted upon. And very importantly, I think, communicating changes that you as a provider make to other relevant care team members for an individual's care team, including the patient and their family, who are always essential members of the care team, if you will, and have responsibilities just as the professional providers do in carrying out a care plan. But HIEs greatly facilitate our ability to communicate to the appropriate persons changes that we make in the care of an individual. And as I said, back to my NFL analogy, everyone on the team shares the game plan. Everyone knows the game plan. And once again, we're not at a point where electronically sharing care plans is a reality. But one of my activities in the standards development area that I'm very passionate about is developing a electronic representation of care plans that can be shared across systems, and care plans that can be dynamic and can change as quickly as care plans do often change. And the important concept here is that we have been able to share care plans as a document, a printed or electronic document for some time now, but those care plans change rapidly, and having a document that's now out of date is not an effective way to coordinate care. We are reaching the point that electronic sharing of care plans is becoming a reality. There are actually in recently released government rules, requirements for sharing electronically care plans for individuals. And those requirements will be coming into play over the next 3 years. So there is something happening that is very important to the future of care coordination. But in the meantime, utilizing this longitudinal record that the HIE provides to view assessments and care plans across different settings of care and in documents that are discharge summaries that have a discharge plan of care is a powerful way to improve care coordination for individuals utilizing that tool, as Dennis described it, of the HIE. And also important, once again, responsibility of the care team members to communicate care plan changes with other team members, including the patient, and reconciling care plans, recognizing that an individual has care plans in different settings where they have been seen that are actually in conflict with one another is an important part of care coordination. The next thing that is analogous to the NFL messages from the sideline is alerts, and alerts based on the data in the HIE. There is in InterSystems technology the capability to set up alerts by providers or by care managers that will monitor the data in the HIE for a particular change on a particular population of patients. So a provider can create the ability in the HIE to be alerted when a certain list of patients have a lab value that is below or above a certain level. So the provider will get an alert and can act on that. And alerts created from analytics that identify patients in a population of patients that are at risk patients is another feature of the HIE. And a separate, very important alert that's coming in the near future is something called an Adt Message. This is old technology that dates to the 1980s that has been given a new purpose because it has been identified that it can have a very powerful value. So ADT stands for admit, discharge, and transfer. This is a function of every hospital administration system that exists. The hospital administration systems generate this message when a patient is admitted or discharged from the hospital, including the emergency department. And the reason for that is that that message is sent by the hospital administration system to the pharmacy system, the laboratory system, the imaging department system, because those systems need to know that a patient is admitted, where they are, and so forth. But it has been recognized that those alerts, those messages can be repurposed to alert the primary care provider or other relevant provider for a patient that they are in the hospital or discharged or have been seen in the emergency department. So we don't have that situation that was in the video clip at the beginning where a patient is in the hospital for a month and their provider doesn't know it. So importantly, part of US regulations that came out earlier this year are that all US hospitals in May next year will be required to send these alerts, these ADT alerts, to the primary care provider and other relevant providers when a patient is in the hospital or is seen in the emergency department. That has tremendous value using a technology that was actually developed in the 1980s to improve care coordination just by creating awareness that the patient had an unexpected problem and was in the hospital or the ED. So that those alerts may utilize Big Sky Care Connect to send those alerts to their intended recipient through direct secure messaging, which is in place, through the HIE in some cases, or direct messages in the inbox of an EHR if the provider happens to be affiliated with the hospital where the patient was seen. So lastly, and this is a bit of a roadmap item, is those scouting reports on the opponents. And for patients and their care team, the opponent is really not another team, but it's the set of diseases, the problem list that individual patient has. Analytics utilizing the data in the HIE make it possible to create risk scores and predictors for individual patients, to create risk stratification based on that data in the HIE. I say this is a roadmap item because the HIE has to be in place and the data has to accumulate for some time before really useful analytics are possible. But my understanding is that that's part of the plan for Big Sky Care Connect to be able to provide these scouting reports, as I'm redescribing them, about patients and their risk as individuals and as members of populations. So with that, I will wrap up and leave a few minutes for any questions. But I will conclude by saying that unlike the NFL, in care coordination, in patient care teams, every team has the potential to have a winning record. And that's where my analogy is dramatically different, is that not all teams can be winners in the NFL, but I think they can be for patients. So thank you for your time and attention. And I will stop and see if there are questions.
Well, Dr. Leftwich, I just want to start by saying thanks for coming and sharing all of your expertise with us today. That was fascinating. Panelists, participants, go ahead and type your questions into the chat, and we will get those to Dr. Leftwich and get those answered if you have them. As we're waiting for some of those to come in, Dr. Leftwich, one of the things I was curious about is when it comes to care coordination of complex patients that you were talking about. I know that in Montana, a fairly rural state, we've got, patients, a patient might be seen by their primary care doc in White Sulphur Springs, Montana, and they may see a specialist over at Bozeman Health, and they may also see a specialist over in Helena, and I imagine your experience in Tennessee was similar. I imagine you had cases like that there with critical access hospitals interacting with large hospital systems. And I'm wondering if you could just share a little bit about, what you actually saw in Tennessee in care coordination and how the HIE there actually helped providers with this piece in a real life scenario.
So there is still not a statewide HIE in Tennessee, but there are HIEs in regions of Tennessee, and probably the best, the exemplar is the East Tennessee Health Information Network that's based in Knoxville, but covers nearly a third of the eastern middle part of Tennessee, and has been able to make great improvements in the care of the individuals in that region, partly, as you say, because the specialty hospitals are in Knoxville, but there are many patients that come to that area from much more rural areas, and although the distances may not be quite as great as Montana, they are still, there is an equal disconnect between those critical access hospitals and the referral centers that are in Knoxville. And the HIE has made a tremendous impact on being able to both get the information from the primary care setting of those patients, but also importantly to promptly get the referral recommendations back to those rural settings where the patients are seen. And I think that same potential exists in Montana, and it does require that people be connected. But I think the value comes fairly quickly in those in that use case you've described, where the patient is their home is in an area that's served by a critical access hospital, but they need care, as often happens in a referral center. That value comes much quicker than some of the analytics and things that I have referred to. Just communication.
Yeah, excellent. Thank you. We do have a question from one of our panelists. Could you comment on the use of DSM in other HIE activities? Sometimes the quarterback, the primary care provider, needs to call an audible and get some quick information from the running back, the specialists. Are physicians utilizing this effectively, and how do they incorporate in their workflow?
Well, I think there are physicians who are doing that effectively, but that's not a universal truth. I think it is a workflow and a responsibility that the providers have to commit to, and the HIE certainly does facilitate that. It even facilitates and can facilitate telehealth, which is, an even better way to enable that interaction between primary care and specialists that you're referring to, and have the HIE is part of the telehealth encounter to share information. Maybe even it doesn't require that the specialists in the primary care be on the line at the same time, if you will, but they can in near real time be sharing information about an individual patient, certainly in the same day and not in the speed of the US mail, getting information from one specialist to a primary care provider.
Excellent. Thank you. Hopefully that answered your question. We've got just a couple of minutes left. I'm going to ask Dennis to rejoin us, see if our panelists have any final thoughts before we go on break at noon. So Dennis, go ahead.
Thanks, Kurt. I just wanted to reemphasize Dr. Leftwich. Some of the things that are happening that he's seen with older patient populations exactly line up with what we experience as well. And number one, medication errors. Many of our kids have psychiatric meds that they're working, through, and in a transition, sometimes that's lost. And I see this as a great advantage for the next caregiver and or provider physician having that good record. And not only we have 4 different psychiatric physicians or caregivers that we work with across the state, and them all being part of this will help in that transition as well. The other thing that I just wanted to follow up on, and I think it's kind of the evolution of information and information exchange. As an old high school principal and working with counselors from day to day, when we first implemented a student information system that all of our counselors had and access to, and eventually all teachers, and now it's even more robust since I've been away for well over 12, 13 years now. But all you have to do is pull the plug on that system after they get it going to really realize the value. And truly, when the electricity goes out, they panicked. It was like, oh my gosh, how are we going to live and how are we going to do our jobs without this student information? And I see it as no different than health information on the children we're serving and the older population, and that demographic as well. So you have to have the playbook, and truly what Dr. Leftwich was talking about, it is a real football analogy. You have to have the information in order to perform. And once that information is taken from you, man, it's really hard to do your jobs. And I think the more providers, the greater this touches all of Montana, and the more providers we get connected, the better we all will be.
Yeah, great point. Thank you, Dennis. Appreciate that. Any parting thoughts, Dr. Leftwich? All right, well, it's about time for lunch. Oh, there's another question coming in. So what are your thoughts on using a care coordination platform with telehealth or remote patient monitoring capabilities that integrate with the HIE data to make the siloed data actionable via attaching longitudinal records to referrals and care teams to those integrated with the HIE network?
Well, I think it has great potential, although the idea of attaching the longitudinal record, that we talk about in InterSystems technology is a virtual thing that you're seeing on your browser, and not something that that can be attached and sent. But I think the idea of leveraging the HIE and that record in telehealth has tremendous potential, and really has just dawned as a concept in this past 9-10 months, that telehealth has had such a tremendous uptake. I have observed in the past that there is a great potential for remote care to be better enabled with that HIE access. And there's no reason that the provider at either end of a consultation type telehealth encounter couldn't be on the same, looking at the same longitudinal record for an individual, certainly. I think, just orchestrating the scheduling of those types of visit would have tremendous potential.
Excellent. Thank you. Well, ladies and gentlemen, it's about time for you to go grab some lunch. So a couple of reminders before we depart. As we heard today, the importance of care coordination from both Dennis and Dr. Leftwich. We need to get as many folks as we can signed up to the Health Information Exchange. So please go out to our website, the Big Sky Care Connect website, and do some research, schedule a call, or just sign up for the HIE. We hope you'll come back this afternoon. We've got some great presentations. You'll be able to learn about the technology, security, hear about how the HIEs can help in pandemics. And later this afternoon, we hope you'll join our Big Sky Care Connect experts, where you can ask some specific questions about Montana's Health Information Exchange, Big Sky Care Connect. So thank you all for attending. Dennis and Dr. Leftwich, again, our sincere gratitude for your expertise and presentation today. And we hope to see you all later this afternoon. Have a great lunch, everybody.
Thank you.
Thanks, Kurt.